Hi, everyone. Welcome to episode 8 of BCG's Health Tech Videos. I am Ariel Rothman, and today's moderator is Jennifer Clausen, partner and director at BCG. We have two exciting panelists here today to discuss value-based healthcare. Simeon Niles is VP of Healthcare Innovation at Morgan Health, and Vinod Shenai is Senior Director of Healthcare Analytics at Village MD. Thank you both so much for joining, and I'll pass it off to Jen now to begin the discussion.
Thanks very much, Ariel. Thrilled to be here today. And Simeon, I think what we'd love to do is maybe get started with a question for you. As we all know, value-based healthcare is a data-driven approach to how we manage healthcare. Would love to hear from you very practically, what measures are being used today to assess the value of healthcare delivered in the US?
Well, I'd say in the employer space, it really depends on your employee population. But first and foremost, you're looking at clinical outcomes as your ED visits, your inpatient utilization, and also primary care visits as well. Of equal importance is the patient experience. You're measuring that through patient satisfaction surveys. You're also looking at the NPS of particular vendors that you might be using, really any type of feedback that as an employer you're getting from your employee base. And patient experience isn't something that I'm unfamiliar with, right? It's really used a lot in Medicare, but its relative importance in the whole landscape of quality is a positive lesson for me in the commercial space. I'd also say, finally, you can't forget about costs. The average premiums for family coverage is up by 7% now, which is much higher than the 2% last year. And so as large employers, we're really looking at ways that we can sort of constrain some of those costs while still delivering high value care.
Thanks, Simeon. That makes a lot of sense. And I heard you talk a little bit about a number of different quality measures. The thing that I also feel is really growing in importance, although not everybody's top of mind, are patient outcomes, which I think are increasingly important and something hopefully we'll see even more of over time. But patient outcomes is another type of data. And so, Vinod, maybe in your experience, could you tell us a bit about how you see data being captured pragmatically and what you see as the role of data evolving as we go forward with value-based healthcare?
So I think in terms of like patient outcomes, for as an example, we definitely look at readmission rates because it's important that the patient is just getting discharged from the hospital and how do we stabilize the patient. And there we use not only claims data, but also then census data, which is the ADT feeds from the hospitals. So that is like a practical example of you capturing that information in real time. As soon as the patient gets admitted, how do we get that information and prepare for post-discharge planning? I would say I'm like +1 on everything that Simeon said. And when it comes to like defining the value of from healthcare, I would say it depends on who is defining the value. So if you look at ACOs, they may say we define value as the savings we generate compared to a benchmark. And the question is that the value? But if you look at employers, they might see, well, my cost of healthcare for employees is going up, so I'm not getting much value from US healthcare. So I think it all depends on like which side of the picture is looking at value of healthcare. And I would say in terms of how the data is evolving, once again, picking up on what Simeon said, I think it depends on, and what I'm seeing is a consumer focus. So to give a few examples, CMS is now talking about what they call as BCDA, which is releasing claims information in 1 week instead of waiting for 2 to 3 months. So that gives ACOs and other providers the ability to take action on patients faster. Then there is information blocking, which means that hospitals have to release information if a PCP patient gets admitted. And then the other ones are including rules on prior authorizations. So I think there is just more of a consumer focus on the data being released. There is also commercial price transparency rules. So I think what we are going to see is that with a consumer mindset, faster data, more timely data, more transparent data will lead to a shift in healthcare and how that information is consumed by all entities.
Great, thank you. And you bring up a really interesting challenge at the beginning of your response there about value and what it means to different stakeholders. In our recent book, The Patient Priority, we defined value as being an improvement in the outcomes that matter most to patients relative to the use of scarce resources, both human resources in terms of healthcare practitioners and clinical leaders, but also costs, financial resources to deliver those outcomes. And if we think about then value-based healthcare the unit of analysis typically is both at the individual level, an individual patient or citizen level, but also at a groups of people who have similar either diagnoses or risk characteristics, et cetera. And so if we think about it from that aggregated level, Simeon, maybe you can give us a perspective on what you see as the groups of patients that are moving faster in terms of applying and seeing results in value-based care.
Well, in the last few years, we saw both employers as well as private equity have a tremendous interest in primary care. And that really sort of is a result of past experience with the success of medical home models. With that, we see population health is still at the forefront of a lot of that, both of a general population, but also of those high-risk populations and those such as those with multiple chronic conditions, where there's a real focus on improving care coordination and reducing, as Vinod had mentioned, hospital readmissions. But what we're now seeing right now is that there's a move towards more narrow, high-cost conditions, such as oncology and pediatrics. And so those are not as tested in terms of value-based care models, but it will be interesting to see what lessons can be learned from previous models as they're applied to these new populations.
That's a very valid point. And Vinod, what's your perspective on what are you seeing working or emerging for that matter?
I would say that some of the population segments which have received a lot of focus include diabetes, CHF-COPD, so congestive heart failure. Their admits are 3 times that of the average population, or the COPD, the chronic obstructive pulmonary disease, their ADK is twice that of the average population. But those have been under like a lot of focus over the past 5-6 years. And what we have seen is that longer those patients cohorts receive primary care, the more stable they get and their ADK stabilizes. So that's in terms of which populations are being focused on. In terms of the emerging, in addition to what Simeon said, I would say that behavioral health is definitely a focus. And then we also have the health disparities either on dual beneficiaries. So these are beneficiaries who are enrolled in both Medicare and Medicaid. Or how do we think about patients who might need some assistance depending on their social determinants of health or race and ethnicity. So these are the emerging frontiers where organizations are focusing on, including VillageMD, to figure out how do we solve those, the need for those niche segments.
No, that's great. And building on what you've both shared in terms of the data, what we measure, and where we see value-based healthcare emerging or already being a bit more mature, I guess another angle that we really need to think about in terms of changing our healthcare systems for the better is incentivizing for value rather than volume. And while contracting and paying for outcomes has its pros and cons, as we all know, I honestly think that incentivizing for value is much better than the fee-for-service system. And so would love to hear, and maybe Vinod, we'd start with you, would love to hear concrete examples of your favorite sorts of value-based arrangements that you see having true impact and working to date.
Sure. So my favorite is total cost of care. So this includes MSSP ACOs or ACO REACH. These are Medicare programs, or even assuming risk for total cost of care with commercial payers. And the reason is that it then puts the primary care provider in the center of the care management, and then the primary care, the PCP can be the quarterback of managing the health of the patient. And the PCP not only thinks about how to prevent the admission, but if the admission happens, how to manage the post-acute. And then there are, in terms of financial incentives, programs like ACO REACH, they give the leeway to ACOs and other entities to enter into financial arrangements with specialists or other providers. So you can really incentivize the downstream providers to deliver the right care at the right cost. And so I think CMS and even the commercial payers, they are thinking of all the right incentives. Total cost of care, I think, really empowers the PCP to take care of the patient and then not only improve the patient outcomes, but also the PCP gets rewarded for all the effort they put in.
Yeah, I'm a big fan of those models as well, the total cost of care, otherwise known as risk-based capitated models, et cetera. So thanks for sharing. Simeon, your perspective, what do you like? What do you not like? What are you seeing out there that actually has real teeth to it?
So I guess I'm gonna have to join the chorus and also say I really like those total cost of care capitated payment models. So prior to Morgan Health, I actually worked at the CMS Innovation Center. So I worked on the direct contracting model, which was the predecessor, short-lived predecessor to the ACO REACH model. And it's, direct contracting and ACO REACH are no simple programs, but I do believe there's something really elegant about capitated payments, in particular, because they allow for those risk-bearing entities to redistribute some of that funding to those providers who are performing quite well. So it incentivizes good behavior on the part of the provider, but also allows for example, through CMMI's waiver authority, incentives to the beneficiary to participate in their own care. I think any type of model that really focuses on centering the patient, but also gives those providers the flexibilities and tools to maximize patient engagement, really have a great deal of promise in being quite successful. One thing I also like about the ACO REACH model, and this goes back to even our conversation around data, is the incorporation of social determinants of health, even in the formulation of those benchmarks, recognizing that patients who may be at an economic or socioeconomic disadvantage may need more resources. It may be quite more difficult to engage those patients. Recognizing those factors in payment models and equipping providers with tools they need, I think is really an important advancement in the ACO REACH model.
That's great. Thanks for sharing, both of you. I'm going to use my moderator's prerogative and ask maybe one last question, a bit of a challenging one. We've talked a lot about the harder stuff, the bit about data, the bit about measurement, about population segments, and also about contracting and arrangements. We've been doing a lot of talking for the last 10 years around value-based healthcare. Would love to understand from you guys maybe what is going to take to really move us forward? What's the true unlock? What have you seen work to change behavior so that we can actually get this at scale?
Maybe I can start here. I think it's just going to take a collective effort, and it's going to be a shared responsibility. For example, CMS, it has set its policy that 100% of Medicare fee-for-service beneficiaries should be in a value-based program by 2030. And that's a tall order because as of now, only 50% of their beneficiaries are in a value-based program. And we have only, about 6 years to go. And this is going to involve incentivizing primary care providers to sign up for value-based care arrangement. I know CMS is trying to make it easy by having a smoother glide path and less downside in their MSSP program. It is rolling out additional programs like Making Care Primary. It is thinking about how to integrate specialists into the total cost of care model. So the specialist episode care models into the total cost of care. So I think having the government play an active role and setting the vision is going to be important. I'm not saying government is the only one who is responsible, but government is definitely a key player given that how big Medicare is. And then I think it depends on, and of course, like providers have to play a big part, but I think it is also the consumer, and more we are seeing the consumers thinking about how much it is costing them out of pocket. And I think the mindset has to shift from managing disease to living in a healthy way. So it's going to really take even need consumer effort to eat healthy, live healthy, and instead of disease progression, hopefully someday we will see a situation where our population gets more and more healthy. So I think it's like a collective effort.
I don't think I'll be as bold to prognosticate on what it's going to take. But what I would say is that I am excited about the potential for AI to answer some of these questions. I think that, right now we speak to and engage a lot of companies, tech-enabled providers who often promise that they can solve some of these intractable issues, either on the supply side with the providers and demand side with the patients themselves, to help bridge the divide and gap between the provider and patient that will lead to healthier behaviors as well as engaging with the health system in a bit more efficient way. It's still to be seen, right? AI is still relatively new. We're still trying to figure out how to work with it. But I'm I'm pretty excited to see what that might be. I think we just need to make sure that we're using it in a responsible way, in a way that doesn't bake in some of the biases that already exist in the system, and that really works to overcome and correct some of those assumptions that can lead for many people to a bad experience of healthcare.
I like your collective responses to our vision of what it's going to take. And so a number of stakeholders working together, I think that's a very powerful model. And I also do think that AI will play a role for sure. I think I fully agree, Simeon, with your concerns that we use it responsibly and that we avoid the biases that are both conscious and unconscious that have been built into some of the data that we'll need to better structure and better bring together disparate data sets so that we can have a truly meaningful data-driven impact as well. So I want to thank you very much both for the time and the insights and look forward to seeing how we can collectively progress value-based healthcare and the outcomes that matter most to patients. Thank you both.